towards the end of the talk. It will be interactive. So I have got the chat box open on my other screen, as well as the presentation. So I should be able to see things in the chat box, or I'm happy if you unmute. And I guess throughout, it's very open and informal. So any burning questions, feel free to ask them. Okay, and I can see we have got at least one liver registrar on the line, but I'll try not to pick on them. All right, so I thought I'd talk to you about neonatal cholestasis, and I'll hopefully think about this in a way that presents to pediatricians across the board. So hopefully not too specialist, but also hopefully not too basic, but things you might come across. It'll be very practical towards the end. I just put that slide in really because it's a good view from the helipad. Okay, so this is something you all should know about, how you form bilirubin and why you get jaundice and the different types. Of course, it comes from the breakdown of the red blood cells forming the bilirubin, and that goes around in unconjugated form. It's with albumin. It's transported to the liver, where it's conjugated by bilirubin uridine diphosphate glucuronyl transferase. Maybe that's a question. I'll test you on the name of that enzyme later. But that's the enzyme that conjugates the bilirubin with glucuronic acid in the liver. Conjugated bilirubin, not attached to albumin, is water soluble. So you excrete it in bile. Because it's water soluble, it goes down the gut and it's excreted in the feces. It pigments your feces brown. It pigments newborn babies' feces yellow or dark greeny color. Most of it is reabsorbed from the gut in the enterohepatic circulation. So you don't endlessly produce loads of bilirubin. It circulates around. Some of it overflows, if you like, into the urine because it's water soluble, and it pigments the urine as well. As you know, if you break down too many red blood cells, so neonate with too much hemolysis, they'll get jaundice, but that's unconjugated. It's rarely a liver problem. If it's a liver problem, really it's a problem with the conjugation enzyme. In Gilbert's, there's polymorphisms of that enzyme. You get a little bit jaundice sometimes. It's Crigler-Najjar type 1 or type 2. Where they don't have that enzyme, they can have particular unconjugated jaundice, but it's just a lack of enzyme. There's nothing wrong with your liver per se. That's unconjugated jaundice. If there's a problem with your liver cells, or you can't excrete your conjugated bilirubin in the bile, then you get conjugated jaundice. And because the water-soluble conjugated bilirubin is not being excreted in the gut, you'll see a pale stool, so there's no pigment in the stool. And then because it's water soluble, more of it will overflow into the urine, so you get dark urine. So the classical way to know what type of jaundice it is to look at the stool and the urine, the pale stool and the dark urine. So you don't need to waste any of your trust's money on expensive tests. You can see clinically. And I would say if you don't look at the stool, particularly in the urine, it's a bit harder to see sometimes, or at least take that history, then you should be doing that to see what sort of jaundice that baby has. So that's important. So cholestasis. So what is cholestasis? It's been defined as diminished bile formation and or excretion. And in the neonate, we use conjugated hyperbilirubinemia, may be present at birth or developing within the first few months of life. What do we mean by conjugated hyperbilirubinemia? We mean that the conjugated bilirubin is greater than 20% of the total serum bilirubin, with a minimum level of 1 in the US units or 17 in the units we use. So say, to remember it, more than 20% or above 20. Bile is formed by the liver cells from bile acids, bilirubin that we've talked about, and fat. It's secreted into the canaliculi, which join to form the larger bile ducts, and then out of the main bile duct into the intestine. And if there's any problem with bile flow, then you get an accumulation of bile salts pre the liver. That can cause the problem of pruritus. Also, you can get high lipids, high cholesterol in the blood, and of course, your high conjugated bilirubin. Is cholestasis the same as conjugated bilirubin? Hyperbilirubinemia? Not exactly, but because we can measure conjugated bilirubin very easily, that's what we would use as a surrogate marker. But you don't really have to have a very high conjugated bilirubin to have cholestasis. You can still have it. You may present with itching, or you may present with fat-soluble vitamin deficiency because you're not excreting bile sufficiently. And it's a final common pathway of any disease affecting the liver. So when we see a child with conjugated hyperbilirubinemia, it's just the pathway, and it doesn't really tell us the disease yet. We'll have to do some more investigations. As you all know, jaundice is very common, about 50%. And usually that will be physiological jaundice or breast milk jaundice. But that, of course, is indirect. And there's probably people on this call who know more about it than me, but particularly exclusively breast milk fed babies, because they have enzymes that break down conjugated bilirubin to unconjugated. So unconjugated is higher, and it also has factors that inhibit the conjugating enzyme. So that's why they tend to be a little bit more jaundiced. But what are the red flags? Who do we investigate? So if they're jaundiced within the first 24 hours or more than 2 weeks, or a new onset of jaundice or particularly high levels, we should take it further and investigate. As I said, you should look at these children. So if they have pale stool and dark urine, that's suggesting it's conjugated jaundice, so they need investigation. If they've got other signs like bruising or bleeding, that would suggest there's a clotting problem, so that may be a liver condition. You should examine the abdomen, of course, so any hepatosplenomegaly, or general signs like failure to thrive, dysmorphic features, or they're unwell, because it may be sepsis as well, of course, within the first 24 hours, or hemolysis. So again, be clinical and examine the children in front of you to decide what you're going to do. So good history and a good examination is always key. What should you do first? Well, the first step is to check the split bilirubin at the 2-week visit. So test for total and direct bilirubin. Direct is conjugated. That's the most simple test to do, and it's a single test that will pick up if there's a real problem. Check the stool and urine color, clinical, to tell if there's a real problem. Then, of course, most of these babies will just be exclusively breastfed babies with normal examination, normal pigmented stool. Then you may want to just see them again and see if the jaundice is resolved according to your protocol. We'll talk about the national, international protocols later. There's another issues, maybe not quite the right word, but the canalicular excretion of bilirubin is rate limiting to overall clearance. So if you have a particularly high unconjugated hyperbilirubinemia for whatever reason, maybe premature, maybe ABO incompatibility or something like that, you often see as that starts to resolve that they actually get moderately high conjugated jaundice as their total jaundice is resolved, and that's just because it takes a while for that to flow through the bile canaliculi. It does vary with age, but we do see that, and that's normal as a very high unconjugated jaundice resolves. I would still recommend anything above 20 or 20% of the total as being abnormal and worthy of investigation. So cholestasis in 1 in 2,500 neonates is never normal, but it's often missed because people assume it's just an unconjugated jaundice or breast milk jaundice. And the time to make the diagnosis does affect the prognosis and some of the conditions that cause it. So referral to a specialist centre is mandated if it exists. And what are the basic reasons that it happens? Well, there's biliary reasons, the main one being obstructive. So you'd have an obstructive jaundice picture. That can be outside the liver, extrahepatic, and the classic one is biliary atresia, or problems inside the liver. It can be problems with the liver cells as well. There's various conditions, and we'll talk about them a little bit later. So looking at this paper from 2015 in Europe, biliary atresia was 26% of the causes that were referred into this review, which was 1,692 children. Another quarter were idiopathic, they didn't find the cause. Then various conditions, and down the bottom, genetic causes of cholestasis, again, were a quarter. There's a few papers of etiology of conjugated jaundice, and it really depends on your referral pattern, which babies get referred to you, what you report. So, but that gives you a kind of spread of what are the sort of things that we see. And then there's a good paper in pediatric clinics of North America on neonatal cholestasis. And you can see there, there's a lot of different causes of cholestasis. So when a child comes to us in King's with conjugated jaundice, this is the kind of things we're looking for in our workup. So the metabolic conditions, some very important ones that you'll be in trouble if you miss. So galactosemia being a classic, tyrosinemia, alpha-1 antitrypsin deficiency, very common in Northwest Europe, as is cystic fibrosis. Obviously, also looking for syndromes. That's why I mentioned examining the child for dysmorphic features. The biliary problems, the classic one being biliary atresia, of course, but also colodocal malformations and Alagille syndrome. Parenteral nutrition is a common cause, so particularly in the neonates, it's extremely common. It can be secondary to other organ problems, so not really a liver problem, but we quite often get referred babies who've had things like HIE, and the liver gets some ischemia as well. Viruses, and some of those can be very serious in the early part of life. And then endocrine causes such as hypothyroidism or panhypopit can all present with a conjugated jaundice. So if there's any trainees on the call who've worked at King's, they will be very used to doing a lot of blood tests on these babies, going through the workup to look for the cause. So the workup. So as I've said, although there's all those blood tests you're going to have to do on these babies, the first thing to do is the history. So when did they become jaundice? What does the stool look like? What are they feeding on? Were they on parenteral nutrition, etc.? Also family history, are they consanguineous, what's happened in previous pregnancies, etc. So a detailed history is important. That will direct you to try and reduce the number of blood tests you're going to do to find the cause. And again, there's papers that are published. So this one in JPGN, this is the guideline for evaluation of conjugated jaundice in infants. And this is the recommendations from the North American Society of Pediatric Gastro and the European Society. So NASPGHAN and ESPGHAN came together to produce joint guidelines. And really, these are what we work by. And of course, sorry, it's just my colleague in the office. So these are what we work by. Of course, anyone can look at that paper. So if you have a baby with conjugated jaundice, you can look at that. And see what you should start to be doing. Okay, so in that paper, it tells you about the history and what to look for. So number one, of course, look for jaundice, though that's not reliable. Look at the stool. That's an acolic stool. That's a very pale stool. Examine the urine. Is it dark? Look at the abdomen, hepatomegaly, splenomegaly. Examine the heart. Is there a murmur? Are you expecting there's any cardiac problems, which there may be in, for example, Alagille syndrome? Also look more generally at growth, any dysmorphic features. Look at the genitalia for thinking of panhypopit, for example. And again, in the guidelines, there's a table showing all of the findings you might see on examination of babies with neonatal cholestasis. Next step after history examination is blood tests. So obviously liver function tests, also glucose cultures, urine reducing substances if you're suspecting galactosemia, cultures if you're suspecting sepsis, alpha-1 antitrypsin level and phenotype. The level is an acute phase protein, so it's not exact. Thyroid function, the newborn screen as well. And the next step after that would be an ultrasound scan. So just going through the liver function tests, bilirubin. The first one, it's easy because it's visible as jaundice. The Simpsons were all jaundiced except there's a deliberate mistake because, of course, the eyes are the first thing or the easiest thing or the place where you will see the jaundice. We've talked about this a bit, unconjugated in excess production, conjugated in either obstruction or hepatocyte dysfunction. The next liver function test, the enzymes, the aminotransferases, ALT and AST. They're not really liver function tests, they're enzymes in the cells, and they're released when the cell apoptosis from whatever reason, so hepatocellular damage or necrosis, for whatever the cause of that is. So not a liver function test, rather a test of how much liver is being damaged at the time. AST is less specific. Muscles has that enzyme, so we always check the CK. It might not be a liver problem, it might be a muscle problem. And again, every year we see a couple of children with muscular dystrophy who are referred to us first because of a high AST. Gamma GT is an enzyme that's on the biliary epithelium. It's not really a liver function test, but again, it tells us when there's a problem with the biliary epithelium. So again, biliary atresia would be the classic for a neonatal conjugated jaundice. Also goes up with some enzyme-inducing drugs. We'll talk about when it's inappropriately normal or low from these conditions a bit later. Alkaline phosphatase, as far as the liver goes, is similar to gamma GT, but it's less specific, and as you know, it's age dependent. Then clotting, very important. It's a good liver function test. It tells you about the acute function of the liver, if you like. So you need clotting factors, which are synthesized by the liver, and it's a marker of how severe the liver disease is, because the liver is not synthesizing the clotting factors. Of note for the neonate, vitamin K deficiency is also a classic cause of a prolonged prothrombin time, or INR. So particularly in neonates, check, has that baby had their vitamin K given to them after birth? If you see a baby with a prolonged PT or INR and they haven't had the vitamin K, give it, or even if they have, give it, and then recheck and see if it was just vitamin K deficiency rather than a severe liver disease. And next, albumin, again, a good actual liver function test because the liver makes it. It's more of a marker of chronic liver disease than the synthetic function of the liver. So it goes down in prolonged liver dysfunction, but it's not specific to the liver. You can lose it in the urine or in the bowel, as you know, or it's nutritional deficiency as well. So that's the liver function tests and the basic screen. And then, of course, you're moving on to second line tests, what your history and examination has pointed you towards. So is this going to be a metabolic condition? Do you think there's infection around? Or do you think it's a genetic cause of cholestasis? So those are the second line tests, hopefully done with some thought rather than a blanket screen. After blood tests, we move on to imaging, and really the imaging you get all the time in hepatology is the ultrasound. So that will look at the gallbladder and the biliary tree. That's why it should be fasting, to try and distend the gallbladder to see if it actually does distend with bile. We can also look at the vascular system through the liver. We look over at the spleen. That's a marker of the blood flow through the liver, through the portal system. After ultrasound, you might go on to doing a HIDA scan or a decider scan or TABIDA scan, whatever you call it, a nuclear medicine scan. looking at uptake of the compound into the liver and then the excretion. Commonly done test, but it's not very specific, and it really tells you a lot of the same things as looking at the stool. After that, maybe an ERCP, so an endoscopic test to actually inject dye into the bile ducts and look at those. After that, more invasive still is histology, so liver biopsy. Still important, although there's a lot more tests these days than there used to be. And finally, surgery and actually looking at the liver, actually injecting the dye into the bile ducts physically at surgery as well. Obviously, that's the final test. So this is an ultrasound scan. So this is in fact biliary atresia, and you'll see some papers about triangular cord sign in biliary atresia. It's this. So it's this echogenicity at the porta, okay? And it's probably some fibrous tissue there. So it's thought this happens in biliary atresia as this fibrosis progresses. It's not been validated across the board in all centres. In King's, we don't use this as a good marker, but some centres do, and I would take it seriously if your ultrasonographer thinks it's there. We would just use the presence of an abnormal gallbladder that hasn't formed correctly as a marker that the child needs further investigation and suspicious of biliary atresia. This is a Hind scan, nuclear medicine scan. So you can see that in A, this is at 1 hour after injection, the liver takes up the marker very quickly, okay? But you can see 24 hours later, it has not excreted the marker, so none in the gallbladder or in the small bowel. So that would suggest biliary atresia, but it's not specific. And a lot of the causes of conjugated jaundice, the nuclear medicine scan, it doesn't excrete the marker very well. And this is an ERCP. So there's the endoscope. They will have injected dye into the bile duct. You can see that this bile duct is very thin and abnormal. So that's a problem. You should be able to see a beautiful biliary tree. This darker bit at the top is the liver, the light bits are the bowel. So you should see a beautiful bile duct, gallbladder, and biliary tree. So this is some obstruction. It's not getting the dye through. So it would be suspicious of biliary atresia. As I said, the next more invasive investigation is a biopsy. That's a normal liver with the portal tract at the corner of the lobule, the liver cells, and the central vein in the middle. This is a biopsy in biliary atresia. So it's hugely different. So there's bile plugs in the bile duct. The blue is fibrosis. So there's huge expansion of the portal tract, forming fibrosis, much less liver cells in the middle. So it's gone from really no fibrosis, a tiny bit around the portal areas, to a huge amount. This is the portal tract with a huge expansion here. We also see in biliary atresia, so look at those nice, even, smooth hepatocytes, compared to this with giant cells and a disarray of the lobules, so quite different. This is a biopsy in Alagille syndrome. So here's a nice portal tract. That's a vein, that's an artery. And the third thing there should be is a bile duct, but it's not present. And it's not present in this one either. So Alagille syndrome, there's insufficient bile ducts present. And in the portal triad, they're not there in every portal tract. This is an intraoperative cholangiogram, so we think it's biliary atresia that go for surgery, and the surgeon actually injects dye into the gallbladder to see if they can demonstrate the biliary tree. And as you can see here, that's a very abnormal small gallbladder, and the dye does not pass out into a biliary tree in the liver or into the common bile duct. So that's consistent with biliary atresia. So as I said, there are national guidelines for how to investigate a neonate with conjugated jaundice. So you can go onto the Busbegan website. There's the link, and that will give you the instructions and tables for what blood tests to start doing in your centre. And when you give us a call, certainly, we would direct you to that and say these are the blood tests we'd expect to start getting done, at least while the referral is in progress. And there's also a nice guideline which you can also look at, which gives you clear directions of what you should be doing in a neonate with a conjugated jaundice. And I would advise you to read them because, as I said earlier, people do miss conjugated jaundice, and doctors do get in trouble if they miss things like biliratresia, and then the Kasai is not successful. So you should be very aware of what to do with a jaundiced baby. Okay, so that was the theory part. Now a bit more interaction. Okay, so these are all real cases as well. So this was a baby boy who was a premature, 26 plus 5 weeks, 780 grams. He was built up to full feeds in his local centre. At day 25, they started him on a milk thickener for reflux concerns. And you can guess what happened. 1 day later, he became unwell, possibly perforated. And he was referred with NEC to surgical centre, which was here. Here they did a clip and drop procedure. If you don't know what that is, they basically put clips either side of the necrotic bits, remove any necrotic bits, but leave the possibly viable bits still present in the abdomen. That's to try and preserve the length of the small bowel. And then a day or so later, they'll go back in, see what's still alive, and maybe join stuff, whatever's left, together. So this baby had that. He had 34 centimeters left at this stage. He went back to theatre the next day. More was lost. He lost his ileocecal valve, and he had a high stoma. So his feeds were built up here, but there was high stoma losses. He was persistently unwell. He had recurrent episodes of sepsis. At 3 months of age, the surgeons closed the stoma to see if we could build up the feeds further, but he had gram-negative sepsis at that stage. He had a stricture at the anastomosis. And at that time, he developed liver disease, and his conjugated bilirubin went up to 754, which is very high. He had to have more surgery, more resection of the gut, a new stoma formed. And he remained cholestatic. So his bilirubin then ran along, even when he wasn't septic, at around 400, which again is severe. So here's some typing you can put in the chat. What would you expect to happen to this baby? So 26 weeker, terrible neck, terrible surgical history, persistently sepsis, severe liver disease with a bilirubin of 400. So what do you think? What would you be talking to the family about? Anyone, or would you just keep quiet? I'll tell you that the family won't be very happy if you just keep quiet. So I'd suggest somebody dares to write a comment in the chat. Would you expect great success? This baby's going to be brilliant. Anyone? So Philip thinks the outcome's dire. Does everyone agree? Owen, consider transplant. Yeah, so the outcome's dire there. Anyone think it's good? There are actually papers on counselling of children like this and what people offer the parents, which is quite interesting papers. Well, this is what happened. He ended up, his liver recovered, normal liver function test now. He grew very well, normal development. His stoma was reconnected, and he went home to school. This is them going on holiday with PN at the time, but ultimately came off parenteral nutrition. So in fact, you can succeed with these babies. I would say Phil and Owen are right. We did think it was a dire outcome, and that is the sort of thing we tell the parents. We did discuss bowel transplant, but with work on parenteral nutrition, intestinal rehabilitation team, you can actually do very well by these babies one way or another. So he did very well, but he was certainly in the group that would consider that he may well need liver bowel transplant. So he had intestinal failure associated liver disease. So you will quite often see it early, particularly in neonates. So at that time, might just be 1.5 times the upper limit of normal range for LFTs. If you did a liver function test, it would be bright, that's fat in the liver. But the vast majority of those will do really well because they're pretty much going to come off PN, they're going to grow, the bowel's going to grow, they're going to do well. It becomes a problem when they start getting portal hypertension, so splenomegaly, low platelets, and a conjugated bili between 50 and 100. That's now significant and needs referral because if nothing changes, in fact, the prognosis is dire. So you have to move on, whatever that is, surgery on the gut, feeding the child, but you definitely need to refer to an intestinal rehabilitation center. When it's late, bilirubin very high, like that child, in fact. The liver's cirrhotic by then, and the prognosis is dire. We certainly do see some children that are referred too late in this end of the spectrum, and they do die, even listed for transplant. They sometimes don't get an organ in time. So you need to pick it up here and do something about it, really, or refer to an expert center. And so the key is identifying the risk group, which are premature short gut type babies, and then get expert help for those. And this is Paris data. In Necker in Paris, their incidence as low as 3% in an expert center. So they can do very well with the correct treatment. Why do prems get it? Their liver is immature, the bile acid pool is reduced, and so is the circulation. They can't transsulfurate properly, and that can damage the liver with taurine. And there's low activity of quite a lot of other enzyme systems. And there's a lot of papers that show the speed of progression of intestinal failure liver disease in infants, and extremely small infants is faster and worse. Okay, so just investigate them, look for the cause, and early expert treatment. Okay, so a different case. So this baby was born on the postnatal wards, but it's hypoglycemic. Your colleague does some blood test results and takes a history. There was a previous sibling who had died. So here are the blood tests. Anyone notice anything abnormal in those blood tests? You can type it or say it. Shweta thinks acute liver failure. Well, she might be right because you can see that INR is very high. It should be 1 and it's 3.2. Some abnormal ALT as well. And the conjugated bilirubin certainly above 20, so that's quite high. So that would fit in a definition of acute liver failure, as long as Shweta they have given vitamin K, because this could all be just down to vitamin K deficiency, of course. So anyone put one letter in the chat what they would do? This is easy. It should be easy after what I just said. Good. So yeah, so the first thing to do is give the vitamin K, because if they haven't had their vitamin K, or the vitamin K deficiency, you can correct the clotting to normal before anything bad happens. So C is the correct answer first. So always with a prolonged INR, we advise vitamin K first. Then you might want to call the liver team after that. So Shweta, very good, you were right. So that is neonatal acute liver failure. So acute liver failure is abnormal liver function tests, INR greater than 1.5 if there's encephalopathy, or greater than 2 if there's no encephalopathy. In a neonate, you can't really tell if there's encephalopathy, so INR greater than 2, and of course, no response to giving vitamin K. That baby actually had gestational alloimmune liver disease. So they're pretty much born with an end stage. It's an end stage, really chronic liver disease because it's happened in utero, but it counts as acute liver failure because it's acute to us when we see the baby. So I don't have time to go in great detail, but there's some interesting papers about that condition. So they are born with a poor condition of the liver. Onto another case, this baby's 5 days old, had been at home and is brought in unwell. So anyone see anything abnormal with those blood tests that they did in the ED? Anyone had something in the chat? Hope you don't think they're normal. Shweta's back in with a acute liver failure again. So yeah, again, that would meet the definition. With an INR of 3.7 and abnormal liver function test, and obviously it's a very young baby, so it's acute. Some people are saying sepsis, which absolutely, this would absolutely fit with sepsis, so be very keen to start antibiotics, obviously, yeah. Natalie says conjugated, yeah, so absolutely, there's a conjugated jaundice here. So this is another A, B, C, or D there. Okay, so yeah, so absolutely, 4 people who've dared to reply, yeah, it's B. Of course, it could be A, but the baby's unwell, so don't rely on that one. Biliary atresia presents lately and not so acute. ABO, of course, well, it's conjugated. That doesn't fit with the ALT or the INR. So it fits with viral infection. So something you want to get onto quite fast. And the key there is the very high ALT. So this is something quite acute. And the big problem or virus that can present very much like that, very acutely with a very high ALT or AST, would be HSV. So we would recommend starting acyclovir in a baby like that, as well as, of course, broad spectrum antibiotics, and whilst you're waiting for your investigations. And at King's, we've done some innovative things to get, and this has serious acute liver failure. These babies are in the group that, bordering on needing transplant. So we've injected hepatocytes into the abdomen. You can see them there. This is the needle. There they are going in. There you are. You can see them on ultrasound scan. These dots are them in the peritoneum, and they're in alginate beads. So in the beads, the immune cells can't attack the hepatocytes, but they can still do the job, and that should do the job of the liver while it's suffering from the HSV until it's able to recover after you've treated it. So interesting things you can do for these babies when they're seriously unwell. Okay, case 4. This baby's 10 days old now. Again, it doesn't look like they've been very well. Lethargy, vomiting, irritable. They are jaundiced when you examine them. The blood sugar's 3.5. Are you worried about them because they look unwell? Okay, anyone want to put a couple of comments what they're seeing on these blood results? Shweta is straight in with metabolic or sepsis, covering a few bases. Owen's for metabolic. Okay, so the bilirubin is very high. It doesn't tell you if it's conjugated or unconjugated. AST very high, so that's telling us there's some very acute and significant damage going on to this liver. White cells are a bit high, so that's going to make you think about sepsis obviously as well. Okay, which test, which is not there, do you want to do next? Shweta says D. I would agree. You want to do the clotting. You want to know if they've got acute liver failure. Also, there's something you can do about that with vitamin K or how serious the child is. So clotting profile is absolutely what you need to do here. So it's the most important test really in an acute presentation with liver disease. And there you go. Very high INR, 4.2. So you're going to be extremely worried about this baby. Any other tests you might want to do? 10 days old, unwell, worried about sepsis, very high AST, and very abnormal INR. Natalie says split bilirubin. You might want to do that, but it's not going to take you much further forward. With an AST of 1,200 and an INR 4, very worried about this liver. So Shweta tyrosinemia, it could be Sophia Natalie Gallipot. Absolutely, I think it would fit with galactosemia. So yes, so sepsis, young baby, and severe liver disease fits with galactosemia. So the treatment is take them off the milk they're on and send them to a liver centre till the liver hopefully recovers. I had one of those just a couple of weeks ago. Very unwell, but did recover. Okay, next one. 7 weeks old now, breastfed baby. Mum went to see the GP because she thinks her baby is jaundiced. GP was very good, or mum was good, and took a picture of the stool. Okay, any comments on the results of your first line blood tests? I like the way that some people make a diagnosis without commenting on the blood tests. Why do you say BA, Shweta Natalie? What is it in the blood that tells you that? Yeah, that was a very pale stool, acolic stool. And in the bloods, high conjugated and high gamma GT, so absolutely. So conjugated jaundice, so half of the total, and a very high gamma GT. So that's an obstructive jaundice picture. So is that 7 weeks old, then you need to exclude biliary atresia. So Sophia's right, it's obstructive liver disease, not necessarily biliary atresia. You have to exclude biliary atresia because you can treat it surgically, but absolutely right, it could be another cause of an obstructive jaundice that presents at that age. Okay, so you need to exclude biliary atresia because they need surgery, but could be any of the other causes. We know that's always clotting. Okay, which test would you like to do? So Owen would like to do the ultrasound scan. That's correct, so that will show you the gallbladder. Is the gallbladder normal or not? That's a good clue. Any other test? I would like to do urine culture. You do want to make sure the child hasn't got urosepsis, yes, and that can present with conjugated jaundice. So you need to exclude urinary sepsis, but it won't really tell you if it's biliary atresia or allergy or something else. Natalie wants to do liver biopsy, yes, that's kind of the gold standard test to look for the findings we talked about earlier. You could do a Hyder scan to see if the bile excretes, but you've seen the pale stool, so you should know the answer, that it won't excrete. Okay, so that's the biopsy, so you'll see bile plugs in the bile ducts, inflammation around the bile ducts, and fibrosis already around the lobule. So that would be fit as biliary atresia. Does anybody know what these pictures show? Allergeal, yeah. So here's the portal tract, vein, artery, no bile duct. There's triangular face, that's butterfly vertebrae, and that's xanthomas, which happens a bit later due to the extremely high cholesterol. So that's Allergeal syndrome, and it can present very similarly to biliary atresia in a neonate. And you often can't really see the dysmorphic features at that age. It's a bit hard to pick up on. Okay, a bit older now, 4 months old. Again, mum's is a bit concerned that the baby's jaundiced. The health visitor thinks it's not growing. Parents are cousins. You examine the baby's small but otherwise well, not dysmorphic, no cardiac problems. The stool is pigmented. So small, jaundiced baby, not much else to find. Oh, I think total bilirubin 10 and conjugated 95 is a typo, but conjugated 95. Any comments on those bloods? Shweta, Natalie, maybe this one's for you. Okay, so Shweta, why, Shagun, why do you say PFIC? What's the reason? That's correct. So the gamma GT is low. So with a conjugated jaundice, you would expect which is a biliary problem, you'd expect the gamma GT to be high. So that suggests there's a problem with getting bile into the bile duct. Another comment on these bloods is the vitamin D is very low, the INR is high, so suggesting there's fat-soluble vitamin deficiency as well in this baby. So poor nutrition, fat-soluble vitamin deficiency, that's suggesting the bile's not being excreted. You've got a conjugated jaundice, but the gamma GT is not raised. So there's a problem before it reaches the bile duct. So that would suggest a type of PFIC, correct? So what are you going to do? One comment for prescribe urso, Shweta for vitamin K. I'd give vitamin K because you need to correct your vitamin deficiencies here, and that's the one that can cause a problem. And also is that really such a terrible liver that iron out of, or is it again vitamin K deficiency? So that's what I'd do first, at least. Okay. So the next steps are trying to investigate what's the cause. So these were the 3 big diseases of the past which had the genes for. And this is a problem. So this is your hepatocyte, this is your canaliculus, and these diseases are a problem on the canalicular membrane rather than the big bile duct lower down. So that's your canalicular membrane. These are the proteins that can have problems. So bile salt export pump, that's pumping out the bile acids, for example. So if one of these has a problem, these cause these genetic cholestatic conditions. And now I'm sorry about the formatting of this slide. So there's lots of different mechanisms of cholestasis, and a lot of these are on that membrane. And now we have the genes for a lot of these. So basically these days you would send off the gene panel. In the past it was more on biopsies and immunohistochemistry. And it's where the problem is on that membrane as to which disease is the problem. So back to that paper I mentioned earlier, there's a nice flow chart in there of what to do with your jaundiced infant. I think that's a nice simple way to think about it, because obviously not everyone can just do a million tests straight up front. So this is how a good way to think about what's wrong and which pathway you're going to go down with your jaundiced infant. That's the end. Thank you. Any questions?
So just whilst everyone's thinking the question, I just wanted to make everyone aware of the feedback form, which I'm going to post in the chat. So please open up the feedback form and leave feedback before you leave the teaching session. We'd be very grateful. And I'll go back to Jonathan for any questions.
So Shweta asks significance of doing HIDA scans. I'd say in specific circumstances they're important, but just as a screen for whether it's biliary atresia or not, they don't tell you any more than looking at for a pale stool. If the stool is pale, the bile is not excreted, so your HIDA scan won't excrete. So only for specific circumstances, I would say, for the HIDA. Complications post biliary atresia surgery. Okay, that's a good one. So for biliary atresia, about a third is successful. About a third have chronic liver disease through childhood, and about a third go on for transplant in early life. Main complications are sepsis and portal hypertension, just progression of the liver disease. Yeah, and the earlier you do the Kasai, the less likely they are to have complications, which is the importance then of paediatricians, community people not missing conjugated jaundice and pale stool, because that early treatment improves the prognosis. Significance of urine reducing sugar in galactosemia. Well, yeah, you should do it if they're on the feed and then be worried about it, but I think it's a bit more difficult with what they're actually feeding as to what results you get, but it's a good screen. Any other questions? I think that's the end.
Thank you very much indeed. It was an absolutely brilliant session. I really enjoyed it and learned a great deal.